Now we will continue with the rest of our accredited portion of our programming. I'm Marlene Neville. I'm one of the members at large on the ASPEN board, and I have the honor of introducing our next speaker, Todd Mattox. Dr. Mattox is a medical surgical clinical pharmacist with a focus in urgent care at the Moffitt Cancer Center in Tampa, Florida. He earned his Bachelor of Science and Doctor of Pharmacy degrees at the University of Tennessee College of Pharmacy, and then completed his residency and fellowship programs in pharmacy nutrition support at the University of Minnesota Hospitals and Clinics. Dr. Mattox also has adjunct faculty appointments for several colleges of pharmacy throughout the state of Florida. And he's been very active in ASPEN and was recently awarded the FASPEN designation in 2020. Dr. Mattox has also been very active with the Board of Pharmaceutical Specialties. So I would like to introduce our next speaker, Dr. Todd Mattox.
Dr. Mattox, we can't hear you.
Let's try this again. I think I'm unmuted. It's one of those rookie mistakes. It's great to be with you here this morning, literally from the home office outside of Tampa here in Florida. I also want to thank the Georgia Aspen Education Committee for the opportunity to present at this meeting. I'm going to attempt to present an overview of a topic that's received much attention over the past 35 years or so, which is immunonutrition, but I'm going to focus on the cancer population. And during that time frame, there's also been multiple publications that have reviewed the accumulated literature and provided recommendations for use of those nutrients. So for the most part, I'll be presenting results of those efforts as a summary for clinical use of what are considered the most relevant immunonutrients in clinical nutrition support of cancer patients. Here are my disclosures. And to kind of give you a more detailed idea of where I'll be headed with this lecture today, first we'll talk about the definition of immunonutrition. Where did that term come from? How did it evolve? Then we'll talk about the effect and mechanism of action of relevant nutrients with immunomodulating properties in cancer patients. We'll also talk a little more about how these nutrients are available, either sterile injectable products or enteral sources. And then we'll review the clinical impact of these nutrients in cancer patients undergoing treatment who require nutrition support.
Hi, Dr. Mattox. Sorry, we can't see your slides anymore. Yes, now we see them.
Okay. So what is immunonutrition? From a historical standpoint, the relationship between malnutrition and infection was really recognized as early as the 1800s, but it really didn't get off the ground in an organized way until the late 50s and 60s. Since then, the nutrition community has continued attempts to further define that relationship by investigating the effect of individual nutrients, either alone or in combination, to affect different aspects of the immune system, almost in a pharmacologic sort of way. And it seems like these concepts began to emerge in a real clinical sense toward the late 80s and early 90s with development of commercially available specialty enteral formulas. And these were relative to development of sterile injectable products. These were somewhat easier to formulate. Further study in clinical applications really supported the evolution of this term immunonutrition And here's a frequently cited definition by Grimble. You see here it's modulation of either the activity of the immune system or modulation of the consequences of activation of the immune system by nutrients or specific food items fed in amounts above those normally encountered in the diet. So I'm having difficulty advancing the slides without losing me. So we'll try this again. There are at least 3 targets that are thought to be potentially positively affected by immunomodulating nutrients to improve response to therapy. They are mucosal barrier function, cellular defense, and local or systemic inflammation. So with that in mind, there have been many nutrients that have been investigated for potential immunomodulating effects, including the antioxidant effects of selected micronutrients, but it appears that a very large portion of the studies of the effects of immunomodulating nutrients during treatment of actual patients has focused primarily on selected macronutrients, in particular glutamine, arginine, and the omega-3 fatty acids and nucleotides. So I'm going to focus on those macronutrients that seem to have the most relevance in clinical practice, particularly in cancer patients. And I'm going to try something here. Let's try this. I think this is going to
Dr.
work.
Mattox, that seems to be working well.
I'm sorry?
That seems to be working well.
Yeah, and again, I apologize to all those in attendance. Definitely some rookie mistakes on my part here. So back to the topic at hand. Let's start with glutamine. It's only one of 2 of these macronutrients with an actual FDA indication, and glutamine was approved for use in sickle cell disease in 2017. Not really relevant to our discussion, but just as an FYI, the mechanism of action isn't fully understood, and it's likely multifactorial, including regulation and prevention of oxidative damage in red blood cells through improved intracellular NAD/NADH ratio. More relevant to our discussion from an immunomodulating nutrient standpoint, it's considered a major fuel for rapidly dividing cells such as enterocytes, colonocytes, and immune cells. It's also been demonstrated that glutamine is a conditionally essential amino acid in that decreased plasma concentrations have been reported in a variety of hypercatabolic situations, such as cancer. Having said that, it's not clear that the decline in circulating concentrations is actually due to depletion. As such, it's been studied primarily as a targeted support for intestinal mucosa integrity in a wide variety of patient populations. This would include surgical trauma, burns, sepsis, and pancreatitis, as well as chemotherapy and radiation patients. And the proposed idea is that decreased glutamine levels result in enterocyte and immunocyte dysfunction. So supplementing glutamine would reduce intestinal permeability, potentially decrease in risk of bacterial translocation, and also reduce severity of mucosal injury after chemotherapy or radiation. Just a few important issues about clinical glutamine use. First, there's still no parenteral formulation available in the United States. The most frequent dose reported in investigations of oral supplementation is 30 grams a day, usually given in 3 divided doses. The IV dose range frequently reported is somewhere in the 0.3 to 0.5 grams per kilo per day. There have been more recent studies that further illustrate that really the optimal dose and timing of use of glutamine still isn't known. And in some cases, use has resulted in poor outcomes, such as reported in the 2013 and 2014 redox reports. For those of you who don't know, the redox study was a large trial that reported on the use of high-dose glutamine, both IV and enteral, as well as other antioxidants in critically ill patients with multi-organ failure, and they reported increased mortality in the glutamine-fed patients. There's been at least one other report of poor outcomes in the cancer, particularly in the oncology population, and that was increased mortality in hematopoietic stem cell transplant patients with IV glutamine use. And lastly here, contraindications to use of glutamine, particularly parenteral glutamine, that have been suggested based on clinical studies include severe renal failure and hepatic failure, although interestingly enough, these are not listed in the actual package insert of the oral glutamine formulation indicated for treatment of sickle cell disease. So in the interest of time, as I mentioned earlier, I'll summarize some of the more recent clinical recommendations for glutamine use in cancer patients. There's been quite a bit of new data published since the ASPEN nutrition support therapy during adult anti-cancer treatment and in hematopoietic stem cell transplantation guidelines were published back in 2009 that have been reviewed very well by the European Society for Parenteral and Enteral Nutrition, as well as the Multinational Association for Supportive Care in Cancer and International Society of Oral Oncology. Here are the ESPEN recommendations. Basically, this is out of their publication, and they directed reportedly on use of glutamine. There's insufficient consistent clinical data to recommend glutamine to prevent radiation-induced enteritis, diarrhea, stomatitis, esophagitis, or skin toxicity. Insufficient consistent clinical data to recommend glutamine supplementation during conventional cytotoxic or targeted therapy, and insufficient consistent clinical data to recommend glutamine to improve clinical outcome in patients undergoing high-dose chemotherapy and hematopoietic stem cell transplant. When we look at the MASCC ISOO recommendations, pretty consistent with the ESPEN recommendations, if even less supportive. No guideline for use of oral or IV glutamine in the hematologic or solid tumor cancers. Cautionary recommendation for use in head and neck chemoradiation due to higher mortality reported with IV glutamine in autologous transplant patients. No guideline for use of oral glutamine in a transplant setting, and an actual recommendation against the use of IV glutamine for prevention of oral mucositis in a transplant setting. So moving on to arginine, this is actually the other immunonutrient that is an actual FDA approval. The intravenous form is a stimulant to the pituitary for release of human growth hormone, so it can actually be used as a diagnostic test for such conditions as panhypopituitarism, pituitary dwarfism, and other problems of growth and stature. Metabolically, arginine also serves as an intermediate in the urea cycle and as a precursor for protein, polyamine, creatinine, and nitric oxide synthesis. Nitrous oxide participates in several regulatory processes such as relaxation and proliferation of vascular smooth muscle cells, angiogenesis, immune response, insulin secretion and signaling, and cell communication. It too is a conditionally essential amino acid during stress conditions and catabolic states, where basically the capacity of endogenous arginine synthesis is exceeded. From an immune standpoint, or an immunonutrition standpoint, arginine's been shown in experimental models to enhance T cell function. It, as I mentioned before, is a precursor of polyamines and proline, which is important in wound healing. It's a precursor to nitric oxide and an intermediary for the urea cycle. The idea how arginine may actually improve responses to therapies is that decreased levels result in decreased nitrous oxide production, compromised microcirculation, immunosuppression, possible ischemic reperfusion injuries, endothelial dysfunction, and compromised wound healing. So supplementation may support these compromised physiologic processes, including organ perfusion, immune function, protein synthesis, and as well as wound healing. From a clinical use in oncology patients standpoint, there's been really little to no investigations in cancer patients as a single nutrient. Most of the data has been used in combination with other immune-enhancing macronutrients as a part of an immune-enhanced diet formula, and much of those investigations have been in surgery patients. The dose studied has been dependent on the patient population studied, and a variety of dosing regimens have been used. Frequently, the oral doses studied have been somewhere in the 6 to 30 grams a day, usually in 3 divided doses. And as you can see, a wide range of IV doses have been used depending on the indication. When we look at the ESPEN recommendations, they really don't directly address the use of monotherapy arginine supplementation. It's mentioned only in the context of perioperative nutrition care, where you see they address use in upper GI cancer patients undergoing surgical resection. As a part of perioperative care, they recommend oral or enteral immunonutrition. So because arginine use has been for the most part started as a part of an immune-enhanced diet, primarily in the postoperative patients, I think it's important to also review recommendations from the Society of Critical Care and ASPEN Critical Care guidelines. If you look at the studies that were actually used to develop those guidelines, many of those included cancer patients. And here you see we suggest immune-modulating enteral formulations, arginine with other agents, including basically omega-3 fatty acids, glutamine, and nucleic acid, should not be used routinely in the medical ICU. Consideration for these formulations should be reserved for patients with traumatic brain injury and perioperative patients in the surgical ICU. And they suggest immune-modulating formulas not be used routinely in patients with severe sepsis. So the kind of the background story for these recommendations is there was early concern that because arginine is a precursor to nitrous oxide, which is a vasodilator, it may be a problem for the septic critically ill patients who is hemodynamically unstable by potentially worsening systemic perfusion. This idea was based on meta-analysis data that demonstrated no benefit or even increased mortality of arginine supplementation in septic patients, but several trials in septic adults demonstrated that it may be in fact beneficial. Having said that, the SCCM ASPEN group felt that although arginine supplementation in septic states is not contraindicated, it's just not recommended due to a lack of consistent benefit, particularly on mortality. Similarly, the recommendation for no use in MICU patients was based on lack of evidence of clinical benefit. On the other hand, there may be an infection advantage in traumatic brain injury and surgical ICU patients because they appear to demonstrate beneficial outcomes, particularly hospital length of stay, infections, and non-infectious complications. So the next nutrient studied extensively for potential impact on a variety of problems actually associated with cancer treatments are the omega-3 fatty acids. We heard a little earlier about the omega-3 fatty acids. These are polyunsaturated fatty acids that are metabolized through pathways that produce relatively less inflammatory cytokines relative to the omega-6 fatty acids, which are metabolized through arachidonic acid pathways. The omega-3 fatty acids also foster production of pro-resolution mediators such as resolvins, protectins, and merisins. These are oxygenated metabolites of DHA and EPA that are kind of analogous to the firefighters that come in to help quell the intense cytokine-induced inflammatory fire after injury. And actually, Dr. Rosenthal will elaborate more on these specialized pro-resolving mediators in his presentation later this afternoon. And this is just a graphical depiction comparing the metabolic pathways of the omega-3 fatty acids compared to omega-6 metabolism. You can see here EPA as it goes through the desaturation and elongation enzymatic changes through to produce these less inflammatory prostaglandins and leukotrienes compared to the omega-6s that that are metabolized through the arachidonic acid pathways. So the idea behind use of omega-3 fatty acids is that they are structural phospholipids in the cell membrane, and omega-3 fatty acids actually play a large role in a lot of cellular activity like cellular signaling, cellular interaction, membrane fluidity, to provide immunoregulatory activity resulting in modulation of tumor metabolism. They also modulate immune response after injury through less inflammatory eicosanoid production and anti-inflammatory mediator production. The omega-3 fatty acids have been investigated for potential impact on a variety of cancer treatment complications, such as neuropathy, aromatase inhibitor-induced arthralgia, tumor response to treatment, and time to tumor progression, as well as effect on oncology therapy-related toxicities, such as diarrhea and mucositis. But really, the areas that have received the most study is effect on cancer cachexia and surgical oncology. From a clinical standpoint, the oral dose is somewhere in the 4 to 6 grams a day of fish oil, or actual EPA or DHA of 1 to 2 grams a day. As we heard earlier, there are 2 IV lipid emulsion formulations that contain fish oil available in the United States. One is a 4-oil emulsion, the other is the 100% parenteral fish oil that's indicated for use in PN-dependent pediatric patients with PN-associated cholestasis. The IV dose for fish oil is 0.1 to 0.2 grams per kilogram per day, according to the ESPEN Nutrition ICU guidelines, which is generally provided with recommended dosing of the 4-oil emulsion containing fish oil. And again, as we heard previously, the adult dosing for the 4-oil emulsion is 1 to 2 grams per kilogram per day, not to exceed 2.5 grams per kilogram per day. And dosing for the 100% fish oil IV formulation is up to 1 gram per kilogram per day. Oral omega-3 fatty acids are available as OTC nutrient supplements or a prescription formulation that's indicated for treatment of dyslipidemias. And naturally, it's also available as a component of immune-enhancing diets. Here's a tabular comparison of those 2 fish oil containing injectable lipid emulsion products. You see here alpha tocopherol listed as a component. This is an antioxidant that's thought to have anti-inflammatory effects as well as a potential role for minimizing risk for development of intestinal failure associated liver disease. This occurs naturally or is added as a formulation antioxidant. The other two comparators here, phytosterol, which is thought to play a role in development of PNALD, and as well as the omega-6 to omega-3 ratio, which is thought to be important from an anti-inflammatory standpoint. So when we look at the ESPEN guidelines, they really mention omega-3 fatty acids in the context of cancer cachexia and use in combination products. Here we see omega-3 fatty acids to improve appetite and body weight. Patients with advanced cancer undergoing chemotherapy and a risk of weight loss or malnourished, we suggest using supplementation with omega-3 fatty acids or fish oil. And then here at the bottom, they address use in perioperative nutrition care in upper GI cancer patients undergoing surgical resection, almost similarly to when their statement about use in with arginine. And lastly, I think it's worth taking a look at the new American Society of Clinical Oncology, or ASCO, guidelines for management of cancer cachexia, where they also addressed role or lack thereof of omega-3 fatty acids. They actually offered no recommendation, but then offered the caveats: it's reasonable to use these fats as a source of calories in patients with cancer cachexia, and then went on to offer natural sources of omega-3 fats such as salmon or nutrient-dense foods that can be included in the diet as tolerated. So I thought it would also be helpful to take a look at the new ESPEN clinical guidelines for ICU patients, because many of the studies reviewed for these guidelines, as well as others, have included patients with cancer. So clearly there's attention to use of both enteral nutrition and parenteral nutrition, and this is reflected similarly in some of the other clinical nutrition organization guidelines as well. Here you see high doses of omega-3 enriched enteral nutrition formula should not be given by bolus administration. That statement is based on an investigation that demonstrated actual difference in outcomes with continuous infusion that was better than bolus administration. Enteral nutrition enriched with omega-3 fatty acids with nutritional doses can be administered. High doses omega-3 enriched enteral formulas should not be given on a routine basis, and parenteral lipid emulsions enriched with EPA and DHA can be provided in patients with parenteral nutrition. Again, not a strong committal for use of omega-3 fatty acids, but clearly an acknowledgement that there is a role. So since fish oil containing IV lipid formulas have been made available here over the past few years in the US, there's been a lot of discussion about their role in parenteral nutrition support. So I thought it'd be helpful to review a very recent meta-analysis that demonstrated a compelling support for some of these recommendations that we have been reviewing. And that's a study by Pradelli and co-authors. Those co-authors also included Dr. Rosenthal, who I'm sure will be talking about this study in the context of the critically ill this afternoon. It was published earlier this year in Journal for Parenteral and Enteral Nutrition, and the aim of the investigation was to examine the potential benefits of an omega-3 containing IV lipid emulsion as a part of parenteral nutrition therapy compared to a standard regimen in adult hospitalized patients. The inclusion criteria for the investigations to be reviewed included randomized controlled trials that included parenteral nutrition with either standard IV lipid emulsion or omega-3 enriched IV lipid emulsion. Any enteral nutrition received had to provide less than 30% of the daily calories provided. There were numerous secondary outcomes investigated, but the primary outcomes were infection rate and mortality rate. In terms of results, there were a total of 49 studies with just over 3,600 patients that were included in the review and meta-analysis. Just under half of those investigations included surgical cancer patients, which, as you would expect, underwent surgical treatment of some type of GI cancer, anything from esophagectomy to major abdominal surgery. Patients are stratified by a level of acuity defined as either intensive care unit or non-intensive care unit. And here you see they reported no significant differences in mortality. However, there was a significant difference in infectious complications, as well as a reduced hospital length of stay by just over 2 days, and a reduced mean length of ICU stay of just under 2 days. So they concluded that omega-3 containing IV lipid emulsions should be used instead of other parenteral formulations that do not contain omega-3 fatty acids. So moving on to our last immunomodulating macronutrient, that would be nucleotides. These are precursors to DNA and RNA, if you'll harken back to biochemistry. So the hypothesis for nucleotide use is that impaired synthesis during injury results in compromise of a variety of physiologic processes where rapid cell replication or tissue proliferation is required. Supplementing with nucleotides promotes structural and functional mucosal integrity, maintains or augments cellular immune functions, particularly cell-mediated immunity. Unfortunately, nucleotides have been most often studied when delivered with other nutrients, such as arginine and fish oil, making it really difficult to kind of tease out the specific physiologic effects of the nucleic acid in some of these outcome studies. And of course, there's no IV formulation that's available. So not a lot, definitely more work to be done in that area. So what I want to do here for the last minutes of the lecture is go through a couple of studies that I think that were recently published that I kind of think tie some of this information about using immunonutrition in cancer patients together. And I think both of them illustrate there's still that we don't a lot that we don't know, but at least these were able to confirm some of the recommendations that we've seen so far. These are two meta-analysis investigations that look specifically at use of immunomodulating nutrients, again, in cancer patients, one focused on surgical oncology, the other on chemotherapy and radiation patients. And I'd like to start with the chemoradiation investigation. The aim of this study was to determine the effect of immunonutrition on incidence and severity of chemoradiotherapy-related oral mucositis, diarrhea, esophagitis, and body weight loss. The inclusion criteria included randomized controlled trials of adult cancer patients who received radiation or chemotherapy. The study cohorts were divided into groups of immunonutrition and standard nutrition, defined as placebo or no nutrition at all. And the immunonutrition group received at least one type of immunonutrition component. Studies evaluated at least one of the following three outcomes: oral mucositis, esophagitis, diarrhea, and weight loss. And primary outcomes included the incidence of oral mucositis and diarrhea. They looked at all secondary outcomes were the incidence of esophagitis, grade 3 esophagitis, oral mucositis, diarrhea, and weight loss. When we look at their results, the types of patients included in the investigations included, as you would expect from a chemotherapy radiation population, head and neck carcinoma, esophageal carcinoma, a variety of abdominal tumors, as well as lung cancer. Here you see they reported no significant differences in oral mucositis, diarrhea, or esophagitis. However, interestingly, they reported significant differences in the more severe stages of mucositis, diarrhea, and esophagitis, as well as a reduction in numbers of, or difference in numbers of patients with weight loss greater than 5%. So their conclusion was that immunonutrition in this patient population failed to reduce incidence of oral mucositis, diarrhea, or esophagitis. It did improve severity of oral mucositis, diarrhea, and esophagitis, and also had an effect on differences in a reduction rate of body weight loss. Moving on to the other study, which was focused in surgical oncology. This was immunonutrition versus standard nutrition for cancer patients, systemic review and meta-analysis. The aim of this study was to determine efficacy of immunonutrition versus standard nutrition in cancer patients treated with surgery. The inclusion criteria, similar to the last one, was randomized controlled trials of adult cancer surgical patients in this particular case. The studies included in the systemic review reported clinical outcomes comparing immunonutrition, including oral, enteral, and parenteral nutrition. Those were compared with standard nutrition supplementation, conventional nutrition supplementation, or saline infusion. Just as an aside, the parenteral nutrition immunonutrition groups, those included PM patients who received glutamine and or fish oil containing IV lipid emulsion. And most of those parenteral nutrition studies were studies of that utilized IV or fish oil containing IV lipid emulsion. The other thing is, it wasn't clear to me what the difference in standard nutrition support and conventional nutrition support would be. Having said that, the investigations had to include an experimental group that received at least one type of immunonutrition component, arginine, glutamine, omega-3 fatty acids or nucleotides, and a control group that did not receive any immunonutrition components. When we look at the results, again, not surprisingly, the patients that were primarily involved in these investigations were, for the most part, gastrointestinal cancer in patients, including colorectal, hepatic, pancreatic, and gastric cancer patients. And as you can see here, they reported a significantly reduced risk of postoperative infectious complications with immunonutrition, but no difference in sepsis or all-cause mortality. Here's a more detailed breakdown of the postoperative infectious complications that were evaluated. You can see here that there was improvement in wound infection, respiratory tract infection, urinary tract infection, and anastomotic leakage, and also a reduced hospital length of stay of somewhere around 2 days. They went further and looked at a subgroup analysis and found some what I call interesting findings. It revealed that perioperative enteral nutrition with an immune-enhancing formulation specifically reduced rates of wound infections. Use of an immune-enhancing enteral formula that contained arginine nucleotides and omega-3 fatty acids also reduced the rate of wound infection and respiratory tract infection. There also seemed to be a dose effect as well. 25 to 30 calories per kilogram for somewhere no less than 5 up to 7 days reduced the rate of respiratory tract infection. And lastly, there was a shortened hospitalized time for malnourished patients who received a immune-enhancing formula. So while the results of these investigations are encouraging, there are several limitations that should be recognized that could affect, the outcomes of their findings, notwithstanding the different kinds and stages of cancers, the differences in the lengths of study periods. These studies also included both enteral and parenteral nutrition in these randomized controlled trials. There was also differences in the timing and number of days of immunonutrition, as well as the doses and active components of the immunonutrition formulas. Presumably these are all accounted for through the meta-analysis process, But I mean, I think it's important to recognize really the variety of the investigations that were used for both of these studies. So both of these investigations clearly add to the notion, excuse me, that there is a positive role for immunomodulating nutrients in oncology patients, but they really provide little specifics for actual clinical application, particularly of individual nutrients, timing of use, and nutrient dose for efficacy, and which cancer patients may benefit. And I really think this information will continue to be important, especially as more targeted therapies are developed. For example, there are ongoing investigations of glutamine and arginine deprivation as a treatment modality for certain tumors. So I'm not sure we know how would use of an immune-enhancing diet containing, larger doses of these nutrients would potentially affect those therapies. Definitely food for future research, for sure, pun intended. So we've talked about a lot here over the past few minutes. To kind of summarize, immunonutrition is the modulation of immune system by utilizing certain nutrients in amounts larger than usually provided in a normal diet. As we talk currently, the clinically important nutrients and most studied nutrients, particularly in oncology patients, are glutamine, arginine, nucleotides, and omega-3 fatty acids. There are several beneficial metabolic effects have been reported in experimental and human clinical trials with use of these nutrients either alone or in combination. But as I mentioned, the role of these nutrients in cancer patients continues to evolve. Surgery, I think, probably has received the most attention. Chemotherapy, there really is a very large second or backseat to data availability. And then again, the numbers of targeted therapies that are coming out literally on a daily to weekly basis is really stunning. And when I read about these glutamine and arginine deprivation studies, this again, I think, shines a new light on kind of the need for more research for studying the effect of these nutrients, particularly in cancer patients. Here are references. Most you saw that were at the bottom of slides. Here are some others additional to those. And now I will attempt to answer questions.
Thank you, Dr. Mattox, for such a wonderful presentation today. We have one question from one of our presenters, or one of our participants. What would you say is the timing of immunonutrition that you would recommend pre-op, post-op, peri-op? What would you recommend in terms of providing immunonutrition therapies for various patients?
I think it depends on the kind of patient that we're talking about. I mean, certainly from a perioperative standpoint, as a part of the early recovery, the ERAS protocols, some institutions have been using somewhere in the 3 to 5 days prior to, or up to a week prior to surgery. Post-op, I'm not sure there's very good data. I know there are surgeons within our GI tumor group that have been using oral supplements post-operatively as well. Perioperatively, it again depends on what kind of what the metabolic state of the patient is in as to which one of these formulas would be appropriate. And I'm sure, again, Dr. Rosenthal will speak more about, in more detail about that this afternoon when he talks about nutrition in critically ill patients. Does that answer the question effectively?
Yes, thank you so much. From our participants, do we have any more questions for Dr. Mattox? If you have some additional questions afterwards, you can always submit these to our chat function, and we can see if we can get those answered later on. I want to thank you, Dr. Mattox, for such a wonderful presentation.